All right, let's start with an introduction in that case. So, sir, I'll let you take the stage first.
Yeah. Yes. Good evening, one and all of those who have decided to be with us for this rapid reporting session. This is one of the first type of a webinar which we have designed it especially for all the radiologists around. And along with me, we have my friend and colleague, who is Dr. Akash, and he's a consultant cardiovascular radiologist at Max Hospital, Delhi. And I'm happy to share that he's also the co-founder of this Quillr software. And over to you, Akash.
Thank you, Dr. Kishan, for that kind introduction. Hi, everyone. I'm Akash. I'm co-hosting our new rapid reporting webinar series with Professor Dr. Kishan Bhagwat. He's a senior consultant radiologist and academician, and the founder of Ayush Diagnostic Centers and Arna Teleradiology, with very vast experience in teaching and advanced imaging and in social radiology. And we are very fortunate to have his expertise with us today because I've seen him personally report even 10 long cases in just 8 minutes. And I requested him to teach that skill to everyone that I could reach out to in my network. And so this is an unconventional webinar where we'll not be teaching you like didactic. It's not a lecture based webinar, but where we will be meeting. And this is the webinar that we'll be hosting every last Sunday of every month. And you can watch Dr. Kishan report cases live while he gives you valuable tips how to do them fast and introduces us to all the tools that he reports that he uses to report fast. So we are starting with chest imaging in today's session, and we will keep you updated with the next sessions on the WhatsApp group that we will create. So you can choose to attend the ones that you're more interested in. So sir will be using a platform called Quillr, which is an AI assistant reporting platform designed to emulate how we talk to a typist to make our reports much faster. So not taking much of your time, I'll just transfer the stage to Dr. Kishan now.
May I request other audience to?
Yes.
Yeah. Thank you. Thank you.
Yeah, thank you. Thank you for inviting us.
Everyone, please mute your mics. We can hear you.
Yeah. Okay. Welcome to the session. And
let me just mute everyone, sir.
Yeah, that's better.
No. No.
I'll just unmute you. So you'll have to unmute yourself.
Yeah.
Yes.
Am I audible?
Yes, you are, sir.
Yeah. Okay. So we'll start this. And there's no financial disclosure or any conflict of interest. And one disclosure is these are the cases that we are doing is they are used solely for purpose of skill transfer to colleague radiologists. So this is to make sure that whatever skills I have, I want to share it with you all. And before doing this session, these are the key terms that we hear every day in and day out. That is turnaround time and error-free report, speed versus accuracy, and time versus productivity. These are the three things. And then one where it comes to skill transfer, this is the one which we are focusing on so that the first three things are addressed, and then utilization of available software tools. And this is how a Quillr login would look like once you sign up. And from here, I'll take you just a moment. Sorry. Yeah. So good to go. Yeah, this is how once you log in this platform.
So we cannot see your screen.
Okay, just one second. Is it fine?
Yes. So you can refresh the Quillr page to clear the everything. Yes.
Yeah.
Because what sir is showing is his packs on the right side of the screen and Quillr on where he will be reporting on the left.
Okay. So today we are doing chest imaging and reporting rapidly how we can report chest imaging rapidly. There are about set of about 8 to 9 cases that we are going to do it in next about 20-25 minutes with inputs from Akash. So my pattern is once I log in, I see the cases. These are the tailored cases for this session. So we will go one by one. So this is a patient who is about 86-year-old with history of pulmonary tuberculosis and low LRTI. He's come for a HRCT. So first I'm going to show for a few cases how I'm going to review the studies. So initially, after the history is seen, most of the time I do a quick review of my images that I'm supposed to report. And this helps us in identifying a few of the things that needs to be identified. In chest imaging, I think lung window, bone window, mediastinal windows, plane, contrast, these form the most important things in the multiplanar sections. So you can see that I've scrolled all the images once, got the clinical history. Now I'm starting to use this tool. Plain CT of the chest. Clinical history is a previous pulmonary Cox now with LRTI for evaluation. Right lung, fibrotic changes noted in the right upper lobe with right apical-posterior pleural thickening and fibrosis. Minimal fibrotic strands noted in the anterior segment of the right upper lobe. Minimal septal thickening and patchy ground glass opacity in the lateral basal segment of the right lower lobe. Emphysematous changes noted in the right middle lobe. Next, left lung. Fibrocavitated lesion noted in the left upper lobe with calcific foci adjacent bronchiectasis and left apical-posterior pleural thickening and pleural fibrosis, which is extending towards the apical segment of the left lower lobe. Minimal fibrotic strands noted in the left lower lobe and in the lingula. Atherosclerotic aortic vascular calcifications noted. Degenerative changes of the dorsal lumbar spine noted. Collapse of the D7 vertebra noted with about 50% reduction in the height with dorsal spondylotic changes. Visualized upper abdomen revealed a right renal calculus measuring about 7.3 millimeter. Left renal hilar vascular calcification noted. Simple cyst noted in the right lobe of the liver. And
So you notice how sir did not have to speak the commas and full stops. All the punctuations are automatically taken care of. And here we see a report being built from scratch with all the findings in all the relevant places. And in the end, we also get an automatic impression that we didn't have to speak out.
yeah, we do get impressions, and we can even, in fact, dictate some lines in the impression.
So if you speak your own impression, it will only put your impression and not generate its own.
Yeah. And once we have a report here, we can use this simple tool to save report or download report and share it wherever it has to go. And we can
Another way
paste
is
it.
just to copy it and paste it.
Paste it. Yeah. We go to the patient number 2. Patient 2 is a 32-year-old male with right-sided neck swelling. This is for a CT chest imaging, including lower neck. It's a plain and contrast study. So we go to the new report here. So before pressing my mic, I usually quickly scroll all the set of images that are important and relevant. It helps us quickly make a picture. If it is a spot on diagnosis, you know what all things to be dictated. So by now we know that there are a few findings. Now you can see how I'm going to report this case. Plain and contrast CT chest, including lower neck. Clinical history is right-sided neck swelling with progressive increase in its size. Observations. There is a large homogeneously enhancing focal mass lesion noted in the right lower neck, which is seen to encase the right internal jugular vein and is also seen to extend inferiorly. There is mass effect over the trachea, with deviation of the trachea towards the left side of the midline. Posteriorly, the mass lesion is extending up to the prevertebral space. Inferiorly, the mass is extending into the superior mediastinum. Laterally, the sternomastoid muscle is displaced laterally. Next line. On the post-contrast imaging, the mass shows a homogeneous post-contrast enhancement. The mass measures approximately about 9.3 centimeter into 7.9 centimeter in its maximum extent on the axial plane. And on the coronal plane, the mass is seen to extend inferiorly into the superior mediastinum and measures about 13 centimeter in craniocaudal extent. There are multiple bilateral axillary lymph nodes noted. Largest of the lymph node on the left side measures about 3.3 into 2.8 centimeter. Largest lymph node on the right side measures about 3.8 into 2.7 centimeter. The trachea is displaced and is narrow due to the mass effect by the mass lesion extending from the neck to the lower upper thorax on the right side. Tracheal diameter is 8.3 millimeter. There are multiple mediastinal lymph nodes noted in the upper mediastinum compressing the superior vena cava. There is multiple right lower paratracheal, subcarinal, precarinal, and prevascular space lymph nodes noted. Largest prevascular space lymph node is about 3.6 into 1.8. Largest right lower paratracheal lymph node measures about 3.7 into 3.5 centimeter. Largest subcarinal lymph node measures 3.4 into 2.5 centimeter. Moderate to gross right-sided pleural effusion with atelectasis of the right middle lobe and lower lobe. Minimal left-sided basal pleural effusion noted. There is edema noted involving the anterior chest wall and in the lower neck. Dash due to SVC compression. Next line. Visualize upper abdomen revealed multiple para-aortic, aorta caval, peri-aortic lymph nodes with homogeneous enhancement without signs of any necrosis nor calcification. Largest lymph node measures about 12 into 13 millimeter at the left para-aortic location. There are few enlarged lymph nodes in the left supraclavicular fossa, largest measuring about 2.3 into 1.8 centimeter. Impression. Multiple lymph nodes noted in the right lower neck, left lower neck with a large lymph nodal mass in the right lower neck compressing the superior vena cava and jugular vein and extending into the superior mediastinum. Multiple mediastinal lymph nodes in the right lower paratracheal, bilateral hilar region and prevascular space, full stop. Bilateral axillary, multiple homogeneous lymph nodes noted. Multiple retroperitoneal lymph nodes noted in the para-aortic region. Edema of the anterior chest wall noted and lower neck noted. Moderate right-sided, moderate to gross right pleural effusion, mild to moderate left pleural effusion. Atelectasis of the right middle lobe and lower lobe with partial aeration of the right upper lobe. Overall features are of lymphoproliferative disorders. Stage the disease. So here I have done the
very complex case.
Yeah, it's a complex case, and then I think the total length of recording is less than about 4 minutes, including the interpretation time. And yeah.
So yes, I see that you asked Quillr to stage your disease. That's very interesting. And in fact, you can even ask for differentials, your staging, whatever. I've seen PGs and SRs not picking up difficult cases, fearing that they will not be able to come to a final diagnosis. Here, Quillr can assist you on every step. So just pick up a case, start describing, even if slow and imperfectly, just describe it and let Quillr guide your report into a more polished one.
Yeah, you can see that it has almost done everything perfectly. So this is a case of lymphoma. And we go to the next patient. This next patient is a 52-year-old with a history of trauma and electrocution. Yeah, many times in trauma, we have a lot of findings. That is also going to take a lot of time to do the reporting. Yeah, we follow the same set of principles, quickly review the set of images that we have so that we know what we are seeing. And this comes with a little bit of practice. And you'll have to do a lot of cases to get that speed of dictation. Yeah. So now we have seen that there's a trauma, there's emphysema, there's a pneumothorax, there's pulmonary collapse consolidation, and then a couple of rib fractures. Yeah. Once we have done, we go for a dictation. CT chest plane, history of trauma and electrocution. Moderate to gross right-sided pneumothorax with a minimal hemothorax noted. Collapse atelectasis noted involving the right middle lobe and lower lobe with partial aeration in these lobes. Right upper lobe appears aerated. Mild mediastinal shift noted towards the left side, corrected left side. Next, go to the bone windows. Next, right-sided first rib, second rib, third rib, fourth rib, fifth rib fractures noted posteriorly. Right third rib displaced fracture in the mid-axillary line, fourth rib displaced fracture. Okay, sorry. Also add right fifth and sixth rib undisplaced fracture in the mid-axillary line. Right chest wall emphysema noted up to the axilla and supraclavicular fossa and lower neck. Emphysema of the facial planes are noted in the posterior chest wall. Minimal left-sided basal hemothorax. No vertebral collapse compression. Yeah, I have finished this case and then I'm updating.
So you see how sir was correcting himself. So if he made a mistake, he just said, okay, look, I meant this, I meant that. So Quillr writes the report based on what you actually meant to say, not what you literally spoke. And unlike sir, if you are slow to speak, take your time and to look for findings is perfectly fine. Speak slow, start slow, speak hesitant, doesn't matter. Quillr will polish it all at the very end when you press update report.
Okay. So this is how we are going to do the report in trauma. So in trauma, usually when we have even facial fractures, many findings are there, then it's very important that we upload all the reports, right? See, and we go to the next patient.
And by the way, sir is not using any templates of his own, but if you have your own templates, you can just use them as a starting point. And Quillr is smart enough to populate your dictation within your relevant places within your template in all the relevant fields. It changes the grammar wherever it's required and does that all on your template, preserving your original languages of the default statements.
Yeah. Team, I'm going to show you what actually I do in my real-time practice when I have a little more workload. And after seeing the initial scans, if I feel they are very simple cases, I will do all the cases at a time. So I'm going to show you those type of cases now.
Okay, so now for these examples, sir will report a rapid fire of multiple cases in just one go. So how you can report multiple cases without having to copy paste one by one, one by one. Just keep looking at your scans one after the other, keep speaking whatever you see, and all your reports will be ready at the very end.
Start. Patient number 1, Sadanandappa, 65 years. Clinical history is intractable hiccups, plain CT chest. Visualized upper abdomen revealed multiple gallbladder calculi. Largest of the gallbladder calculus measures about 8 millimeter. Gallbladder is contracted. Hiatus hernia noted at the G junction with the part of the stomach above the level of the gastroesophageal hiatus. Minimal plate atelectasis noted in the lingula of the left lung. Few movement artifacts are noted in the lower thorax during the imaging. Degenerative change of dorsolumbar spine. Mildly prominent esophagus noted. Minimal atherosclerotic aortic vascular calcification. Atherosclerotic coronary calcification. Impression. Hiatus hernia noted with the part of stomach above the level of G junction. Minimal plate atelectasis in the lingula of the left lung. Multiple gallbladder calculi. Recommended upper GI endoscopy in view of a dilated upper esophagus. Next patient. Chandrama, 53 years. History of cough. Plain CT chest. Right lung. Bronchiectatic changes with fibrosis and adjacent consolidation and volume loss noted in the right middle lobe. Pleural thickening noted in the anterior costal pleura, adjacent to the right upper lobe. Minimal fibrotic change noted in the left lower lobe. Left lung hyphen. Minimal bronchiectasis noted in the left lower lobe. Few fibrotic strands noted in the left lower lobe. Overall features are indicative of a sequelae of pulmonary cox. Also add a few small volume subcentimetric precarinal region lymph nodes noted, largest measuring about 19 millimeter into 11 millimeter. Atherosclerotic aortic vascular calcification noted. Add this in body of report only. Go to next patient, patient number 3. Clinical history is sputum positive pulmonary tuberculosis, plain and contrast CT chest. Right lung. Bronchiectatic changes with fibrosis and cavity formation noted in the right upper lobe in the posterior segment, with the bronchiectasis and cavity formation also noted in the apical segment of the right lower lobe. Few patchy consolidation in the both upper lobe noted. Multiple tiny reticular nodular lesions are noted involving both lungs in all the segments. Few small volume mediastinal lymph node, largest in the right lower paratracheal region, measuring about 7 millimeter into 6 millimeter. Full stop. Visualized upper abdomen appear unremarkable. Impression. Overall features are of active pulmonary tuberculosis with coexisting sequelae of pulmonary cox with miliary type of pulmonary tuberculosis. Then create 3 separate reports and mention a patient number at the top of each report.
This way of reporting is actually unique to Dr. Kishan because even we as founders did not know that Quillr could do this, but he introduced this. This is how I'm using it, and we were pleasantly surprised that he was creating multiple reports in just one report update. And patient-wise, you can just copy and paste it in your respective patients in your portal, reporting portal, wherever you're reporting. All you did was like look at the scan and describe it like you were describing it to your colleague or to your typist or even to your PG. Just describe anything and your reports will be ready.
Yes, this is how it is done. So you can see that patient number 1, 2, and 3, and go and respective. And believe me, I do about 10 to 15 reports at a go, and Quillr doesn't fail. And that's the best part of it. And yes, we do have to do corrections sometimes, and we need to be very careful as well. So we can't be complacent, because Quillr is giving us the additional time to look at things more carefully and methodically. That's what I believe. We go to the next patient. Yeah. Next patient is a 65-year-old patient with plain radiography showing a mass in the left upper lobe, upper zone. So it's a plain and contrast CT chest. So now I'm going to show you, from now on, I will not be reviewing the scans beforehand. So I'll be dictating the findings as I start seeing the cases. And this will come after you practice for a couple of cases. You can also start doing this. Plain and contrast CT chest. Left lung, hyphen. There is a large heterogeneous necrotic mass lesion noted in the left upper lobe in the apico-posterior segment, which is abutting the pleura. However, no rib erosion noted. Full stop. Medially, the lesion is extending up to the arch of aorta, and inferiorly, it is extending up to the left pulmonary hilum. Minimal atelectasis of the lung noted adjacent to this mass. The mass lesion measures about 6.1 centimeter into 6.1 centimeter in its maximum extent in the axial plane. Craniocaudally, the mass lesion measures about 7.6 centimeter. There are few prevascular space lymph nodes noted. Largest measuring about 14 into 10 mm. There are few precarinal lymph node noted, largest measuring 8.5 into 5.8 centimeter. Small pulmonary nodular lesion are noted in the left lung at the upper lobe. Dash a pulmonary metastatic nodular lesion measuring about 5 millimeter. Minimal degenerative change of dorsolumbar spine. Minimal sorry, delete that. No adrenal lesion, no demonstrable focal liver lesion noted. Impression, left upper lobe pulmonary malignant mass lesion with extent as described, and multiple ipsilateral as well as precarinal region, mediastinal lymph nodes noted. Small pulmonary subcentimetric metastatic nodule noted in the left upper lobe. No lytic or sclerotic lesions in the Julius bones. No adrenal lesion. No hepatic focal lesion. Stage the disease in the impression. Stage the left pulmonary malignancy in the impression.
So you can ask you to stage any disease. Just name the staging system, TNM, TIRADS, BIRADS, anything, and to follow that and give you the staging automatically. But please note that this is only suggestive. You will have to cross verify if the staging is done accurately or not.
Yeah, we can go to the next patient. Akash, how much time do we have?
I think 10 minutes, so 5 minutes with this patient, this case, and then we can conclude with a few things that I want to show.
Yeah, we can go to the next patient, the last
Yes.
one. Yeah. Yeah, again, this one we will do on the go, like when we are reviewing. The same way we are dictating, we are not reviewing it beforehand.
And maybe, sir, this case you ask it to diagnose it for you, like ask it for differentials instead of
Yeah,
giving
okay.
an impression.
Sixty-year-old lady, plain and contrast CT chest, history of tiredness, cough, history of carcinoma breast 7 years ago. Post right mastectomy related changes noted. Multiple pulmonary nodular lesions noted. Largest of the pulmonary nodule measures about 8 millimeter into 9.3 millimeter in the right upper lobe with spiculated margins. There is a large pulmonary mass lesion noted in the lingula of the left lung, extending up to the left hilum, measuring about 5.1 into 3.7 centimeter. There are multiple mediastinal lymph nodes noted in the prevascular space, aortopulmonary window, precarinal, subcarinal region, left peribronchial region. Largest of the lymph node is in the left peribronchial region, measuring about 1.9 into 1.2 centimeter. There are a few hypodense, minimally enhancing lesions noted in the both kidneys. Right kidney measuring 17 into 9 mm and left kidney measuring about they're not measuring about 13 mm into 11 mm. There are sclerotic foci noted in the lumbar vertebrae at the L2 and dorsal vertebra at the level of lumbar L2 vertebra sclerotic foci and at the level of D10 vertebra, indicative of skeletal metastasis. Create an impression and also mention differential diagnosis for this.
And maybe also ask for further steps of management, what to advise the patient next.
Also add further steps of management for this patient.
Yes, please make sure that all your dictation points are printed before you press update. But you can stop the mic and let's wait for it to print because it was a long dictation.
Nice.
So we can stop the mic. It will send the audio faster. Because so yes, so this way of reporting for expert radiologists, it puts the love of radiology back into reporting, and for inexperienced ones, it removes the fear of reporting complex cases. You just ask it to assist you in every step of the way.
Yeah, here what I say is it's a metastatic disease and also synchronous primary lung malignancy, less likely granulomatous disease. I think we can definitely remove the number 3 from the report because 1 and 2 are good enough, and recommended tissue biopsy from the accessible lymph node and also PET CT also. So everything is there. I think this is giving us more time to look at the image. I think regarding this, Akash would tell more.
Yeah, so this is helpful for both all inexperienced till experienced radiologists. So I will add one point, like in case you're reporting a complex case and you want to learn from what you just reported, you can even ask Quillr to teach you that case, the approach to that case, and in a tabular form, you can ask it to make note from that, like how to reach a specific differential. So it will create a table for you. It will tell you how to differentiate each differential based on different sequences. So that way also you can just ask it like it's a Siri for radiologists. Just ask it whatever you want it to do and it will follow. So now I'll just share my screen and I want to now give you a bit of cheat codes to report even faster. Although I don't recommend using it this way, but yes, in times when you are short of time, you can always do this. I'll just share my screen. Now, for example, because we are doing chest, I'll just try to do one case. So for example, you're reporting a case HRCT chest and you come across ILD that you just made the diagnosis in your head. And you know it's almost the same similar kind of report every time. So just to instead of having to describe everything word by word, line by line, you can just ask Quillr to do that. Let's say I'm reporting HRCT chest and there is ILD of UIP pattern. Describe the findings of UIP and make a report. So we have trained all the pathologies with their textbook descriptions inside. So you just name the pathology and ask you to build a report. And first you'll have to tell the study that you wanted to do or do it on, and we'll do that perfectly. So it has all the pathologies and all the description, the classical descriptions for this. If you want to edit it, you can say or add or remove certain things, giving follow-up commands like do this, do that, and we'll change it accordingly based on your current report. But majority of us, we have our own reporting styles, we have our own reporting formats, we have our own way of describing each pathology. So that way also it can come in handy. For example, I have my own template to start with. So I'll just load up my template. And what I can do is like go to macros. Macros are the shortcuts for long statements that I can save. Like for example, UIP, this is the language that I wanted to just describe it in. So I can save the descriptions in my macro box, enter the description, giving it a name and adding it to the box, to the window. Once we've added it, the macro to our list, we are ready to use it. To use a macro, all we need to do is say the command macro followed by the name. I'll give you an example how we do that and why we call it a smart macro. Let's say this is my normal template, macro UIP, and make the honeycombing more in the right lung rather than in the left lung.
Akash, your screen is not getting shared, I think. Just check.
Okay.
I'm stopping my screen share.
Okay.
Yeah, now it's there.
All right. So let me just start, for example. So yes, so this is a normal template that I have. This is what I do. And you can just save your shortcuts for long statements by going to the macros button. Here I have saved my UIP as the this is how I like to describe my UIP in this language exactly. So I have saved that as a shortcut. So I'll just say macro UIP and make the honeycombing more in the right lung rather than in the left lung. So it will tailor my macro, change my macro to update it to reflect my current findings so that I don't have to do that manually once it's inserted into my report. So here it's done and it's in my own language now. So this is how you can make it faster if you don't want to. Like, for example, you're reporting a complex case and you made a diagnosis in your head. I'm reporting MRI of pelvis and there's right-sided grade 1 AVN and left-sided grade 3 AVN. And there is also appendicitis. Describe the findings and build a report. So cases like this, for example, degenerative spine or your atrophic brain. So these fast cases can be reported in matter of seconds. So it will describe and expand AVN according to their pathologies, AVN 1, AVN 3, and then we have appendicitis along with the normal treatments and the things that are supposed to be ruled out in all those cases. So this is how you can report it. So I'll give the stage back to Dr. Kishan.
Thanks, Akash. I think that was a very good insight into what we are planning to do it. And I think this is where what I wanted to say. I'm sharing. Yeah.
Okay.
Yeah, turnaround time and
So,
error-free report is what is most important. What you saw just now is a radiologist can turn around within the stipulated time. Usually, there is always a pressure over a radiologist, be it a medical college or a scan center or a online reporting. There's always a pressure. This software has taken out that pressure from us. And generating error-free report is like how much ever good MTs you have or how much ever good you are yourself are good at typing. Even then, you can't match a machine because it does the mundane task more easier. And speed versus accuracy. As we increase our speed, our accuracy reduces. That is how it works. But with Quillr, you don't have the tension of who is going to type this whole lengthy report. So even when we get a report there, and then we can do it fast. And the pressure for us to creating a report is gone. And then time versus productivity. Yes, definitely we get a lot of time and we become more productive. And then I think I've tried my best and Akash has tried his best to utilize these 30-35 minutes to do some amount of skill transfer to you people and utilization of available software tools. And I wholeheartedly welcome anybody who wants to spend a week's time at my office wherein they can be with me. They can do shadow learning from me by going through all my reporting on a daily basis, whatever I'm doing. And then at the same time, you can learn doing it yourself. And Akash also would be happy to give you a Quillr during that period of 1 week when you stay with us. And for beginners, it will be very good for you because you wouldn't have still decided which subspecialty you are doing. And for those who have planning to take up some exams and those things, you're always welcome to spend a week along with me. And you can see from my packs about maybe close to a lot of thousands of cases are there. So you could see it and train yourself for the exams. This is what I can wholeheartedly invite you all. I think Akash is going to tell you some more things.
okay, so can you stop sharing your screen so I'll share mine?
Yeah.
Okay, so we have some questions in the chat box, so I'll try to answer those. So if you want to access Quillr, this is a what we call it as an. So can you see my screen first of all?
Yes, yes.
Okay, so this is an AI assistant for radiologists or Siri for radiologists, how we like to call it. And this is designed to almost double your speed of reporting. Like, for example, we know that we only spend about 30% of our time scrolling through our scan and the rest 70% goes into editing, typing or reports. If we can cut down this amount of time, we can almost double the report in half the time. And not to mention the mental burnout that we face at the end of the day, that is taken out. And this is a website that you can just log into Quillr.ai and make your account and start to free to start with. First few days you'll get to free to test it out all the features, and at the end of your free trial you'll get the subscription link with all the pricing details. So someone asked me what's the pricing. So we keep running different offers. So prices fluctuate from top to bottom. We have some lucrative pricing sometimes, like Diwali offer or New Year offer, something like that. So you'll get the latest pricing list once your trial has ended, but it's very economically priced at like around 1/10 the cost of hiring a typist is what it is priced at. I can the ballpark figure. So for people attending this webinar, we have a special offer. You can get 15 bonus days of extra days of Quillr usage if you use the code RAPID while you're signing up on our website, Quillr.ai. If you want to contact me or Dr. Kishan directly, you can take a screenshot of this. And this is my phone number, personal number, and this is Sir's personal phone number that you can contact on. And this is our website if you want to send us any message. So that's it from all of us. And we'd like to hear how your feedback on how the session went and what would you like us to improve in the next one. And every last Sunday of every month, we'll be hosting a new body part, like a new system that we'll be taking. This was chest, and maybe next time will be abdomen. And this way you can attend whichever is more suitable to you. So, sir, if you want to have any closing questions, I'd like to do that. I'd like to take them. I'll try to see the other questions that people have posted.
Yeah, there are some questions like I think what are the references used for staging and providing differentials?
So yes, the references, whatever you ask for example, TNM staging, it will use the latest TNM staging, AJCC, the 8th version, which is out. Or if you want to use this classification system, it will use that classification system for you. So we have updated it with the latest system as and when the new updates come out.
Do we need internet connection for it to work? Yes, I think
Yes.
whatever you saw just now is about 350 Mbps. And if at all those living in cities, if you can get an industry speed of 450, that is the most ideal if you're reporting PET CTs and all that.
Okay. So yes, it works even on a basic mobile phone, mobile networks. You can use it using through a hotspot. So any basic internet connection works. All you need is a normal mic to talk to your system. It does not have to be a fancy mic. I'm currently talking directly into my laptop, or you can use AirPods or Bluetooth headphones. That is all it needs. But internet connection is required. Sir, I don't have the chat with me, so if you can tell me
The
the
next
questions.
someone is asking, Mr. Srinivas is asking for average cost. I think he can send a message to Akash's number, or you can
So yes,
flash
sir.
it. Yeah, if you have the.
So I'll give you a ballpark figure. For example, monthly cost, it costs 3,500, which is the regular pricing, but we keep offering multiple discounts, so it comes down to 3,000 rupees a month plus taxes from time to time.
I think there are no more questions.
Okay.
Yeah.
So we'll share this recording of this session of the people who are not able to attend it from starting till end on the WhatsApp group that we'll
There's
be creating for all of you.
one more query, that is Kruti Priya is asking, how can I do the observership at your PACS? For this observership, you need to be physically there at our office for 1 week's time. So if you're a beginner radiologist, if you can spend a month with us, that is always great. Because online, I wouldn't suggest, because the way we are looking at images, you need to learn from an experienced person, or you need to spend that much amount of time looking at image. If I've dictated something in 3 minutes, that 3 minutes is evolved over a period of 20 years. And for you to learn that fast, you need to learn those tips one-to-one with us. So I would say that if somebody wants to do an observership at my tele-reporting office, they're always welcome from Monday to Saturday. They can reach here by Monday, and then they can be here till Saturday evening, and they can leave. I'm based out of central Karnataka in Davangere. We are connected to Bangalore by about 4 hours, and then there's an airport nearby. Shimoga is the nearest airport. Those who want to travel from far off, or the airport from Bangalore is about 5 hours. And 1 week's time or 10 days time, depending upon your requirement, you can talk to me one-to-one. It's more like a friendly thing, so that they can come and see, because we report a lot of cases in body imaging as well as PET CTs, and other than cardiac work, everything else we report. So you can be part of do an observership of how we are doing it. So that helps you to go back and do your piece of work. I think
Okay.
that answers Kruti Priya's observership. Yeah.
So if there are no more questions, we can end the session. We have actually overshot the time that we had allocated.
That's fine. Okay, thank you, Akash. I think it was good. And thank you for everybody who has hanged on till the last. And it's good to meet you all at the beginning of the session. We would love to invite you on every fourth or every last Sunday of the month for next 1 year or couple of months. And if you have any suggestions to make on how to improvise the sessions, myself and Akash are open for discussion. Thank you.
We have one question.
Yeah.
What's the order of the checklist?
For reporting for X. Yes. If you have noticed me, I'm always going by the right lung, left lung. I'm seeing those lungs, and then I'm looking at the mediastinum. Then I'm looking at the bones, and then I'm looking at the ribs, and then I'm going back to the pleura and these things, and then I'm going to the upper abdomen. So this is my order of review. And with Quillr, the order of review need not be fixed, because if you had seen my first case, I was reviewing the studies, and then again I was dictating. At the end, I showed you how I am reporting now. If I see a calculus in gallbladder and CT thorax, I report it there, because I know Quillr is going to put it in the abdomen. It's not going to do it up and down. So it's always better you go up to down and you go from center to outside. This is a basic. So you can design it the way you want so that you don't miss. And everybody has review areas. That is, I keep missing something in the clavicle fracture every time. I have missed so many times. Whenever it is a CT trauma chest, I only look at the ribs, but I used to miss clavicle. So for me, clavicle is a blind area. So in my pattern, I will look at the clavicle twice. So same way, over a period of time, you will have your own blind review areas and you will have your pattern. So best way is up to down and center to outside. That's a good way. Yeah. I think that answers Ekalavya's question of what is your order of checklist for reporting. Yeah.
Thank you for that question, Ekalavya.
And I think Bhaskar Mani has thanked. It is very informative and easy of new reporting era in radiology. Okay. I think we are done with. I think we can sign off now.
Okay. Thank you everyone for your time and enjoy the rest of your Sunday. Thank you, sir.
Yeah, enjoy everyone. And a happy new year to everyone.
Yes, happy new year to everyone. Bye, sir.
Bye.